Hi friends, my name is Dr. Varun Deshmukh, and in this video we are going to discuss about very basics of invasive mechanical ventilation. I have been requested by many juniors and many nurses online as well as in person to cover this topic, and I think this is very important and very vast topic and it is too big to cover in a single lecture. So probably we will divide it into various parts and one by one we will discuss these topics in each lecture. So in this particular video I am going to discuss about the basics, what happens when we ventilate a patient through the invasive ventilation technique, what are the various modes, and what are the initial basic settings that we need to keep. So I hope you like this video, and for more videos definitely subscribe to my channel and share these videos with your friends and colleagues who might also be benefited from this. So first of all, when do you initiate invasive ventilation? So as the name suggests, invasive ventilation means we have to deliver the positive pressure breaths, which include air as well as oxygen, into the patient's central airway. So this can be via endotracheal tube or via a tracheostomy tube. So these are the two methods through which we can invasively deliver the breaths. So obviously when the non-invasive method fails, so the oxygen via nasal or face mask or HFNC or BiPAP, these all fail and patient is still requiring oxygen, or patient's work of breathing is too much and we want to reduce that, or patient's oxygen demand is too much. In these scenarios we may have to resort to invasive ventilation. What happens is the machine mixes oxygen and air as per our initial settings and delivers the positive pressure into the central airways, and then eventually it goes into the peripheral airways up to the alveoli, which leads to inflation of the lungs. Whatever the mode that you have set, whatever the settings that you have kept initially, depending on that there is a certain expansion of the lungs, and when the expansion stops, when the inspiration stops, the expiration process starts, and in the expiration process passively the inflated lung comes back to its previous size, and the air which was inhaled comes out through the expiratory port of the ventilator. So this is the process in principle. Now technically we will discuss what are the needs, what are the indications where we will have to put patient on invasive ventilation. So if you start from airway first, so problems with the central airway, problems with the distal airways, problems with the alveoli, and problems with the pulmonary vasculature. So problems with the central airway. So here whenever there is a mass or a laryngeal edema or laryngospasm, here the air is not able to enter through the central airway and go past it to the distal airways. So in these scenarios we may have to pass a tube through the obstruction and pass it beyond the obstruction to facilitate the delivery of the air as well as oxygen. So mind you, in these situations we may have to use a firmer tube which contains metallic rings, which is known as flexometallic or reinforced tube. So this will not get collapsed easily when there is a laryngeal problem. So this is the indication when we need invasive ventilation for central problem. Now the distal airway problem. So here alveoli, here the distal airways are affected mainly in the form of constriction. So acute exacerbation of COPD, acute exacerbation of asthma, who fail the non-invasive sort of various ventilatory techniques and oxygen therapy, these patients also may have to eventually put on invasive ventilation. Coming to the alveolar problems. So any fluid in the alveoli, so be it pulmonary edema which is cardiogenic or non-cardiogenic pulmonary edema or ARDS, pulmonary hemorrhage, these are the situations, and severe pneumonia of course. So these are the situations where alveolar problem is there and the air exchange is not possible. You can maximize the delivery of oxygen by invasive ventilation. Another indication is problems with the vasculature. So whenever there is an obstruction in pulmonary artery, the blood cannot reach the alveoli and gas exchange cannot happen. So in these situations, mechanical ventilation per se would not help much, but it will definitely improve the efficiency of the blood, of the oxygen reaching the alveoli. So if you give 100% oxygen, perhaps whatever oxygenation is taking place, the efficiency may improve. So these indications include pulmonary embolism or thrombus, which may be a blood clot, it may be amniotic fluid embolism, or it may be air embolism or fat embolism. So these are the vasculature related problems. The other set of indications are based on the breathing process. So if there is a hypoventilation, that can lead to decrease in the oxygenation and increase in the carbon dioxide, and that can eventually lead to respiratory failure. So indications for hypoventilation, so most common is general anesthesia. When the patient is planned for any elective surgery or procedure, generally if the anesthesia that is selected is general one, then we are giving medications to suppress the patient's consciousness. At the same time, patient's respiratory drive is also getting suppressed. So in these situations, you have to resort to invasive ventilation. Another important indication is when the airway protection is needed. So because of the loss of consciousness or depression of the sensorium, the patient may not be able to handle the own oral secretions, and sometimes these secretions tends to enter into the airway. Ideally, the patient should have ideally be able to spit the secretions out, or should swallow the secretions. But when the patient is not able to handle because of drop in the sensorium or because of the incoordination of the muscles, so in this situation also, for protection of airway, for prevention of aspiration pneumonia, you may have to put the patient on invasive ventilation. Now this is about the central hypoventilation and airway protection. Now there are other indications where peripheral nervous or neuromuscular problem is there, and that leads to hypoventilation. So starting from the anterior horn cells, then going into the motor nerves, then the neuromuscular junction and muscle. So maybe if I can give you examples, poliomyelitis, tetanus, Guillain-Barré syndrome, myasthenia gravis, various myopathies, severe hypokalemic periodic paralysis. So these are the indications where you may have to eventually resort to an invasive form of ventilation because of hypoventilation. Another important indication is diaphragm weakness or paralysis. When there is injury or insult to the phrenic nerve, the diaphragm nerve supply may get affected and the movement may reduce, and it will lead to hypoventilation. So in this situation also, you may have to resort to invasive ventilation. Another indication is the flail chest or trauma to the chest. So in this condition, when the ribs are fractured at multiple levels, positive pressure ventilation is helpful and is indicated. If there is a massive pleural effusion or massive pneumothorax, in these situations also sometimes putting patient on invasive ventilation becomes necessary. So these are the various indications of using invasive ventilation. Now we will discuss what are the different modes of invasive ventilation. So historically, the most ventilator dependent mode is CMV or controlled mandatory ventilation. If you go below that, so less ventilatory dependent mode, that would be assist control. Even below that would be intermittent mandatory ventilation, or even less ventilator dependent would be SIMV, synchronous intermittent mandatory ventilation. And if you go further down the line, there is pressure support. So we will discuss these various modes in short details, in principle, and we will go forward. So whenever there is a word control in name of the mode, that means you can set the rate in this particular mode. So be it CMV, be it assist control, be it SIMV VC or SIMV PC, in all these modes you can set the rate. That is the control which is in your hand, and of course depending on whether it is volume control or pressure control, you can set tidal volume or pressure. So we will discuss that. So in CMV, in principle, there are two options, volume control CMV and pressure control CMV. As the name suggests, you can set the rate, as M suggests, mandatory. So whatever parameter you have set, for example volume control, you have set a volume of 500 ml and a rate of, for example, 20. The ventilator will deliver 20 breaths of 500 ml tidal volume to this patient. If you have set an inspiratory pressure of say 20 in a pressure control CMV, in this situation the ventilator will deliver a pressure of 20 during each inspiration for the set rate, in our example at a rate of 20. So that is the CMV. The problem with CMV is when the patient becomes awake and patient starts to breathe on himself or by himself or herself, the ventilator does not accept the patient efforts. So ventilator will give only those breaths which are set by you, and you have to very actively keep on monitoring for change in the ventilatory settings. So this is practically very difficult, and if it is ignored, then the patient will have lot of ventilator asynchrony. Patient might cough, may not be ventilated well, and eventually may lead to tiring of patient, may lead to hemodynamic instability, and sometimes even barotrauma. So CMV is not a great mode unless patient is completely sedated and paralyzed. Just one step below CMV is assist control. So in principle it is same as CMV, but it is little different. As the name suggests, it assists the patients in breathing. So here also you can set the respiratory rate because there is control in the name of the mode. It can be volume control assist control or pressure control assist control. In volume control you can set a tidal volume, in pressure control you can set an inspiratory pressure, and the rate also of course you can set. The main difference compared with CMV here is whenever the patient triggers for a breath, the machine allows the extra breaths. So suppose you have set a rate at 20 and patient starts to wake up, or patient comes out of your anesthesia, or patient's power improves, patient will try to take breaths and patient is taking 24 breaths. So 20 breaths are already set, and the 4 extra breaths that the patient is taking will also be allowed. Since it is a control mode, the machine will give the same setting for each extra breath. So your tidal volume, say it is 500, for extra 4 breaths also the machine will give 500 ml tidal volume. And suppose your pressure, it is a pressure control, and your pressure was for example 20, the machine will give 20 pressure during the breaths, even if they are extra breaths. So the problem here is that there may be hyperventilation or breath stacking because the machine is delivering with the same tidal volume or the same inspiratory pressure even with the patient generated breaths. So that is little bit problematic, but that becomes a problem when the patient rate is very high. If the patient rate is near to the set rate, this problem would not happen. Now the modern ventilators that we have, the most ventilator dependent mode is assist control. CMV is not there in most of the ventilators which are produced now. So the most ventilator mode, the option that you have is assist control. If there is only volume control or pressure control, it is implied that it is assist control volume control or assist control pressure control. Coming down to the even less ventilator dependent mode, that would be intermittent mandatory ventilation. So that means and it can be volume control or pressure control. So here also you can set the respiratory rate, and depending on volume or pressure control mode, you can set volume or pressure, and the ventilator will give set parameter at a set rate, and patient will be able to breathe in between. The difference from assist control here is that each breath which is patient generated will not be assisted. So whatever the patient's effort may be, the breath will be according to that effort. So the tidal volume may be 20 ml, it may be 50 ml, it may be 100 ml, depending on the patient's effort. And if the patient is taking more breaths, sometimes the ventilator may give a breath on top of that because it will give at a set rate, whatever rate you have set. So here sometimes the patient's work of breathing may rather increase because your set ventilatory rate may not be adequate. So even a little bit more refinement into the IMV and SIMV mode was developed. So IMV, there is a synchronization. So when the mandatory breath is going on, at that time, just before and after few milliseconds, if the patient triggers a breath, ventilator will abolish the mandatory breath and let patient breathe. So there is some sort of synchronization between patient and ventilator. Now even less ventilator dependent than SIMV is pressure support. So here the patient himself or herself generates a breath, and ventilator only gives pressure during the breath. Breaths are not controlled breaths, so you cannot set rate here. You can just set pressure here, and whatever pressure you set, that much tidal volume according to the patient's lung mechanics will be generated. So you have to see the tidal volume, see patient's rate, patient's effort, everything. So that is the pressure support. Now logically, if you think that if you start to wean a patient, so yes, when will you wean the patient? You will start thinking about weaning when the patient is put on invasive ventilation. And in principle, the indication of the invasive ventilation should resolve, or should at least start to resolve, for you to attempt weaning. So we suppose we think that the indication has resolved and now you are trying to wean the patient. So the way in which I told you, you may have been on VCAC, then you can come down to IMV or SIMV and then PS. But the trials or various observational studies that have been performed so far could not show any benefit of SIMV. So what they say is either you put patient directly from VCAC to PS, or you can put directly from VCAC to TPs. TPs is just simple oxygen and no attachment of ventilator at all. So depending on the patient's parameters, you can take that call clinically. But giving or putting patient on SIMV may rather increase the work of breathing and may rather prolong the weaning process. So now when will you use SIMV? So in our practice, we don't routinely use SIMV alone. We use it as a SIMV plus pressure support. So whatever patient's own breaths were would be supported with a pressure support, and whatever mandatory breaths are will be supported with your set tidal volume or your set pressure. SIMV plus PS we use for chronic patients who do not get weaned soon because of various problems, sometimes critical illness neuropathy, sometimes other neuropathies or myopathies, or sometimes problem with the electrolyte or some endocrine problems. So these patients, we select SIMV plus PS, and we start with intermittent short trials of SIMV PS, gradually increase the duration of SIMV PS. If the patient is able to tolerate that, we gradually start reducing the rate of SIMV and let patients take more breaths, and eventually over a few days we go to PS and wean these patients. So for weaning, in a prolonged weaning scenario, we use SIMV plus PS. Otherwise routinely we do not use SIMV plus PS. So that's how the different modes work, and I hope you have understood and it is clear to you how these modes work. Now what are the initial settings for you to keep? So whenever you intubate a patient, I think we will discuss the process of intubation in a separate video. But when suppose you have intubated the patient, you have confirmed the position of the AT tube, then you come to the ventilatory settings. So you start with 100% oxygen level, FiO2 100. You have to select the mode. So in our ICU, as a default, for a initiation, we select volume control or volume control assist control, and sometimes with or without autoflow. So for example, we are selecting volume control mode. We select a tidal volume. Tidal volume is generally 6 to 8 ml per kg of predicted body weight. This is a formula of predicted body weight which you can see on your screen. Apart from tidal volume, you have to set a respiratory rate. To begin with, we set a respiratory rate of 12 to 18, in that range. If we have intubated for hypoxia or patient is in lot of distress and patient's previous respiratory rate was say above 30, in these circumstances keeping a higher respiratory rate is beneficial, because whatever metabolic acidosis was present would have been compensated with patient's hyperventilation, and if you start with normal ventilation, normal minute ventilation, then perhaps you will accumulate CO2 and you will decrease the patient's pH. So depending on the patient's previous parameters, you have to select the rate. You have to also select the PEEP. Generally, as a starting point, PEEP would be 5 or 6 centimeter of water. If the patient has pulmonary edema or ARDS, you will select a higher PEEP. We do not give high PEEP to patients with unilateral lung problems, like a unilateral one lung which is involved with pneumonia, or any problem which is just on the one side. Higher PEEP will not be beneficial. The PEEP will be applied to both the sides, and the normal lung will be affected with high pressure. So you have to keep that in mind. Another thing that you have to see is I/E ratio. So various ventilators have various mechanisms to for you to set. So in some ventilators you can directly set I/E. Generally it is 1:2. in some ventilators you have to set the inspiratory time. So based on your respiratory rate and inspiratory time, your expiratory time will be counted. For example, if you have set a rate of 20, each breath will be of 3 seconds, because in a minute, in 60 seconds, 20 breaths are going to be delivered. So for 3-second breath, if you keep inspiratory time of 1 second, the remaining 2 seconds will be your expiratory time, and I/E ratio will become 1:2. If you have set a rate of 30, then in that case your each breath will be of 2 seconds. So to keep a ratio of 1:2, you have to reduce the inspiratory time to 0.66. So I hope you understood that. So depending on the respiratory rate and your I/E target, you may have to reduce or increase the inspiratory time. Another thing that you need to know is the trigger. So initially, when the patient is on fully ventilator dependent mode and may be sedated or paralyzed, trigger may not be of that use. But once the patient starts making effort, trigger comes into play. Trigger means an indication for the ventilation to understand that patient is demanding for a breath. So the trigger can be of two types. It can be flow trigger or pressure trigger. If there is a flow trigger option, we keep at 1 or 2 liters per minute. If there is a pressure trigger option, we keep at -1 or -2 centimeter of water. When the patient takes an inspiratory effort and this much flow is generated within the circuit, or this much pressure is generated within the circuit, the ventilator will understand that patient needs a breath and ventilator will deliver breath. Since we are on assist control, the ventilator will help patient take breath with the same setting that you have kept. So this is about the trigger. If you keep a higher trigger, the patient may have to make a higher effort in terms of flow or pressure to inform the ventilator that I need a breath. So it will be difficult for the patient if the trigger is high. That's why we keep at 1 to 2 liters or -1 to -2 centimeter of water. So this is about trigger. What more you should know? There is an option of inspiratory pause. So inspiratory pause generally is given at the end of inspiration. There is a pause of 0.3 to 0.5 seconds and then expiration starts. Generally this is given to prolong the inspiration. When there is pulmonary edema or alveolar problem, the idea is to increase the duration of inspiration to enhance the oxygenation. But generally we do not use inspiratory pause in our day-to-day settings. One more thing is sometimes there is an option to set flow also. So generally the flow is 40 to 60 liters per minute. If the patient has high demand, you can increase the flow. If you want to have a prolonged expiration, in that case also you have to increase the flow. So for example, in asthma and COPD, you may have to increase the flow up to 80 to 90 or even up to 100 liters per minute, depending on the I/E ratio and depending on the patient's clinical condition. Higher flow means the same tidal volume that you have set will be delivered in a shorter time, or higher flow means the inspiratory in the same set inspiratory time at the same pressure, the higher flow will go. So that will lead to delivery of more tidal volume. And if we are on a volume control, the inspiratory time will become short and it will give more time for the ventilator to for the patient to exhale. So this is about the flow. So I think these are the basic ventilatory settings to begin with. Once you put patient on ventilator, you have to monitor the hemodynamics. You have to monitor the take care of any pressure source, any corneal exposure to air. So prevent that by putting moisturizer, putting the artificial tear eye drops. When patient is sedated, all the things which happen to the patients become your responsibility. So you have to take care of the nutrition, you have to pass a catheter and make sure that hourly urine output is being monitored. You have to take care of the prevention of DVT, you have to take ulcer prophylaxis, and at the same time you have to start thinking about weaning this patient off the ventilator. So that is about the patient on ventilator. And once patient is put on ventilator, after 1 hour or so, you should do an ABG to see how the patient is doing and whether you need to change any settings. Generally, whenever we start with 100%, if the lungs are not the main problem, lung pathology is not the main problem, we can come down on the oxygenation depending on your ABG parameters. So that's all about the initiation and the beginning of the ventilator and some basics about the various modes of ventilation. I hope you like this video, and I will come up with the follow-up lectures on the same topic. And I hope you share this video with your colleagues and subscribe to my channel. And that's all from me today.